Dr. Justin Deskovich, a fellow in training at NextGen Institute of Physical Therapy. I'm here to demonstrate a few techniques at the shoulder girdle and the glenohumeral joint itself. It's very interesting that if we do not have good scapular control and/or scapular mobility, we do not have a platform for the glenohumeral joint to move upon. So a lot of my shoulder patients that do have decreased upward rotation of the scapula or poor mobility of the scapulothoracic joint, I really feel and believe that the sequence of mobilizations are absolutely critical. What we'll demonstrate today is that sequence of mobilizations. We'll start with the Scapulothoracic Distraction. Have your patient in side lying with their arm comfortably rested on their sides. They can have their knees up slightly for patient comfort. If you're treating the patient's left scapula, you're going to bring your right arm underneath their arm. Go ahead and relax. And you're going to use your body to retract the scapula so you can get underneath the scapula. Sometimes you have to give them a little cue to relax so you can get under there. And that's usually what happens. The first time the patient is not going to let you get in there, so you have to give them some tactile cues to relax, or you're not going to be able to truly distract the scapula. These mobilizations can also be progressive. We can start with the straight distraction. We can start to bring the shoulder in a bit of upward rotation as we distract. After I do my scapulothoracic distraction, I like to go after the inferior capsule inside lying. It's a comfortable patient for the comfortable position for the patient. I'm able to stabilize the scapula very nicely, and I can get a good proximal control on the humerus as I stabilize the scapula to truly stretch inferior capsule. We do not want the whole scapula moving with this, for we might cause some impingement features. So this stabilization is absolutely critical as we mobilize the inferior capsule. After those two, we can have the patient go into supine. Let's go on your back there. And scoot all the way over to the side of the table for me. Next we will be doing a posterior glenohumeral joint glide. Let that elbow relax. It's very important that you think about the congruency of the joint. It's not a straight posterior, it's actually a little bit of a posterior lateral glide. You're using your thigh closest to them to stabilize their body and the scapula. Have the patient relax. Sometimes you need to do some physiologic oscillations. And then we can come in and do our mobilizations in a posterior lateral direction. These can be graded 1 through 4. You can even thrust in this position. It's a pretty safe area to thrust in as well if need be. Also, varying degrees of shoulder internal or external rotation can be incorporated. If you bring in a little bit of shoulder internal rotation, sometimes you'll get a better barrier at the posterior capsule as you do your mobilization. It's critical that the patient has feedback with you. So, are you feeling this in front? And I always tell the patient, you should feel pressure in front, but stretch in the back of your shoulder. If they get any lateral arm pain, little minute adjustments might be necessary to truly mobilize the posterior capsule. After my posterior capsule mobilizations, I then work into the final component of this sequence of mobilizations, which would be an inferior glide. Test the patient passively if they're restricted around 90 degrees, which is common in a lot of our shoulder pathology. We can start the mobilization there. Proximal control technique, inferior glide of the glenohumeral joint. You actually want to see the axilla move. And if you can see the axilla move as you do your inferior glide, you now know you're getting the inferior aspect of the capsule. The caveat on this technique is that it can oftentimes be tender, particularly in post-operative patients. So you want to desensitize that area, do some lower graded mobilizations before you really get in to move the capsule. Once this patient has achieved greater than 90 degrees of abduction, we want to bring the humerus further into the range and then glide the humeral head inferiorly. If we do not have a progressive mobilization here, the patient may never get full range of motion again. For example, if all we do is mobilize here for 25 visits, that may be all the motion they ever get. So then we have to start bringing them up. And again, use your body, support their arm with your forearm and hand. You can really get into the axilla nicely here. And then you can see that axilla move as I glide here inferior laterally. After our mobilizations, we want the patient to do some sort of movement right away so we can reset the muscle spindle in the newly acquired range. They might do an active assistive range of motion exercise, and after that I would follow it up with a functional exercise. Okay.